Bismillah ar-Rahman ar-Rahim. This is Professor Abdul Salam Yasin Taha from the College of Medicine, University of Sulaimani, giving a talk on one lung ventilation without double lumen endotracheal tubes. You can watch this lecture and other lectures by visiting my YouTube channel using the URL at the bottom of the slide. The learning objectives of this lecture: what are the techniques available for one lung ventilation apart from double lumen tube? Define and give a brief history of bronchial blockers. What are the modern types of bronchial blockers? Describe their features, advantages, and limitations. Learn the techniques of bronchial blockers insertion through demonstrating videos. Know the indications to use bronchial blockers. Know the role of conventional single lumen endotracheal tube as a lung isolation technique. Compare the three available techniques of one lung ventilation with each other. So to start with, what is one lung ventilation? One lung ventilation refers to mechanical separation of the two lungs to allow ventilation of only one lung, while the other lung is compressed by the surgeon or allowed to passively deflate. There are three available techniques for one lung ventilation: the double lumen endotracheal tubes, bronchial blockers, single lumen tubes advanced into either the right or left mainstem bronchus. Well, the double lumen tubes have been discussed in a previous lecture, and the other two techniques will be the subject of our present lecture. So in this picture, you can see a demonstration of the three techniques of one lung ventilation. The one on the left side is the double lumen tube, which is the Cohen's technique, and the other two are the bronchial blockers and the single lumen endotracheal tube. What are bronchial blockers? Bronchial blockers are devices used to occlude a mainstem bronchus and thus preventing ventilation of the lung distal to the site of blockage, and sometimes they are used to achieve a selective lobar collapse. The method of deployment: bronchial blockers are placed either intraluminal within a single lumen tube, i.e. coaxial fashion, or placed separately adjacent and outside the single lumen tube. That's the parallel fashion. Bronchial blockers are of different types. Old varieties which have been designed over the years never exist nowadays, while the modern bronchial blockers are continuously invented and introduced into the clinical practice. So if we go into the history, we will see that in 1938, the Swedish surgeon and pioneer of controlled ventilation, Clarence Crawford, described the use of a ribbon gauze tampon attached to a cord and introduced endoscopically through the lumen of an endotracheal tube. So that is the Crawford gauze blocker, which might be the oldest and simplest method of bronchial blockade. And in 1936, McGill achieved bronchial blockade using a long tube with an inflatable cuff at its distal end that was advanced alongside a single lumen tube using a rigid bronchoscope. So that is the McGee bronchial blocker, which never exists nowadays. We have a number of rubber bronchial blockers which have been designed over the years but never exist nowadays. They are demonstrated in the slide. So bronchial blockade can be classified into balloon-tipped catheters, such as Fogarty embolectomy catheters, Foley's catheters, and pulmonary artery wedge pressure catheters. And the modern bronchial blockers, such as the Ardnt wire guided endobronchial blocker, and the Cohen bronchial blocker, and the uni blocker of the Univent Tube, and the Bifid EZ blocker. Now, these four varieties will be discussed in this lecture. So, Foley's catheter, as well as a pulmonary artery catheter, can be used as devices to achieve bronchial blockade, as well as the Fogarty occlusion catheter, which is a vascular tool, can be used also as a method of bronchial blockade. The Fogarty embolectomy catheter is a balloon-tipped catheter with a removable stellate. In the parallel fashion, the Fogarty catheter is inserted prior to intubation, while in the coaxial fashion, the Fogarty catheter is placed through the endotracheal tube. Both techniques require fiber optic bronchoscopy to direct the Fogarty catheter into the correct pulmonary segment. Once the catheter is in place, the balloon is inflated, sealing the airway. Fogarty embolectomy catheter has some limitations. It has no lumen, therefore neither oxygen insufflation nor CPAP are possible. It is made of latex material, and this might induce latex allergy in some patients. And it has a balloon of low volume and high pressure, which is well, in the following two slides, we have two videos which will describe and demonstrate the insertion of three modern bronchial blockers: the Cohen bronchial blocker, the Univent Tube, and the Ardnt, or the wire-guided endobronchial blocker.
This is a bronchial blocker. You can use this as an alternative to a double lumen tube for isolating a lung. It's basically a tube exchanger that's hollow and with a cuff at the end. And using a regular endotracheal tube, you can pass this bronchial blocker down into either the left or the right lung. And once you're in your correct placement, you just simply inflate the balloon to isolate the lung. Let's look at some of the other materials and setup and placement of the bronchial blocker. One method to placing this bronchial blocker utilizes a special adapter which comes with the bronchial blocker itself. As you notice, it has 4 ports. The bottom port here connects to your endotracheal tube. This side port allows for connection of your circuit to allow for ventilation throughout the blocker placement. This top one with this rubber gasket allows for placement of your fiber optic scope down the endotracheal tube. The gasket seals, that way you can still provide positive pressure ventilation throughout the blocker placement. And this other port over here on the side allows for placement of your bronchial blocker. Once the bronchial blocker is advanced past the level of the scope, you can visualize seeing the twisting motion which directs the bronchial blocker into either bronchus. Another method we have to placing a bronchial blocker is using a specialized Univent Endotracheal tube. The difference about this endotracheal tube is that it has two lumens. One lumen is dedicated for the bronchial blocker. The other lumen is used for ventilation as well as the fiber optic scope. Once the tube is in place, you simply pass the scope down the ventilation lumen and advance your bronchial blocker, directing it into either bronchus. One disadvantage to this tube is that while you are placing the blocker and confirming placement of it, you cannot ventilate the patient unless you have the scope taken out. Once you've intubated the patient, go ahead and advance your fiber optic scope down the endotracheal tube to the level of the carina. Once there, advance your bronchial blocker to the same level. And using a twisting motion, you can direct the bronchial blocker into either the right or the left main stem. To isolate the right lung, use a clockwise turning fashion on the bronchial blocker to direct into the right main stem. If you want to isolate the left lung, use a counterclockwise twisting method to direct into the left bronchus. Once you are in your correct bronchus, go ahead and use the syringe and inflate the cuff, thereby isolating the lung. After you've inflated the cuff and isolated the lung, go ahead and remove your scope, making sure to close the gasket, that way you maintain positive pressure. And on the bronchial blocker, there's a metal stylet at the end. Go ahead and remove the metal stylet, thereby exposing the lung to atmosphere. This will deflate the lung. If you need to help deflation of the lung, you can take a luer lock syringe, place it on the end of the bronchial blocker, and suction out even more.
The Ardnt endobronchial blocker is intended for endobronchial blockade of the left or right lung for procedures which require one lung ventilation. One lung ventilation is commonly required for surgical procedures and is normally achieved using a double lumen endotracheal tube.
One of the advantages of using this blocker set is that it can be used with a conventional endotracheal tube. The 3 millimeter diameter does not significantly compromise the cross-sectional area of the endotracheal tube, such that there is no noticeable change in resistance to airflow through that. The placement of the blocker does require adequate lubrication, and I think the lubricant of choice in this situation is an aerosolized silicone spray. The other gel-type lubricants can interfere with the optics of the bronchoscope as the bronchoscope is passed through the endotracheal tube.
A special bronchoscopy port, the Ardnt multi-port airway adapter, allows simultaneous bronchoscopy, ventilation, and endobronchial blockade. Assembly of the device is straightforward. With a conventional endotracheal tube correctly placed above the carina, the Ardnt multi-port airway adapter is attached to the tube. It then connects to a standard anesthesia circuit, and the patient is ventilated with 100% oxygen. The Ardnt endobronchial blocker uses a monofilament guide loop assembly, which fits through the lumen of the endobronchial blocker and exits from the blocker's distal end to form a small, adjustable monofilament loop. A pediatric fiber optic bronchoscope is advanced through the guide loop to couple the bronchoscope and the endobronchial blocker together. This may be done within the multi-port adapter, endotracheal tube, or within the trachea proper. The endobronchial blocker and bronchoscope may also be coupled together prior to attachment of the multi-port adapter to the endotracheal tube. This coupling allows the endobronchial blocker to follow the bronchoscope. The guide loop can be adjusted to facilitate proper approximation. Once the carina is visualized, the bronchoscope is advanced into the section of the lung which is going to be deflated. After the area to be blocked is entered, the bronchoscope is held stable and the loop with the endobronchial blocker is advanced and pushed off the end of the bronchoscope. After slight retraction of the bronchoscope, the endobronchial blocker may be either advanced or retracted to place it in final position. Under bronchoscopic vision, the balloon is inflated with air using the pilot balloon assembly. The balloon should fill the entire endobronchial lumen to be blocked and not herniate into the main stem trachea. The lung should be carefully auscultated following initial bronchial blocker placement and balloon inflation to ensure proper functioning of the endobronchial blocker. If ventilation should be acutely difficult during endobronchial blockade, the balloon should be immediately deflated. The bronchoscope can then be withdrawn. The blocker port of the multi-port adapter is tightened, ensuring that there is no escape of gas and that the blocker does not move within the multi-port adapter. After assuring that the blocker is in the correct lung, the balloon is deflated and the bronchoscope port closed. The patient is positioned for their surgery, and once again the balloon is inflated to allow the surgery to proceed. It is important to deflate the balloon prior to final positioning of the patient, because some movement of the endotrachea or carina can occur. Once the position is confirmed, the guide loop can be withdrawn from the central lumen of the blocker, and the lung deflation can begin. The guide loop assembly cannot be replaced within the endobronchial blocker once it has been removed. Once the loop is removed from the blocker, the lung will deflate both passively and through absorption atelectasis. In addition, deflation can be assisted by direct aspiration with a syringe. The blocker's central lumen can also be used to deliver CPAP with the enclosed adapter.
Well, there are several indications for the use of a single lumen tube with an endobronchial blocker set, and I use it in both the setting of thoracic surgery as well as the setting of cardiac surgery.
Contraindications for use of the Ardnt endobronchial blocker include an airway diameter insufficient to allow passage of the endobronchial blocker and the unavailability of fiber optic equipment. Potential adverse effects which may result include hypoxia, hypoxemia, endobronchial irritation or injury, and tracheal injury. This device should only be used by those familiar with the use of pediatric scopes and airway anatomy. The use of pulse oximetry is recommended when using this device. Available in 5 French pediatric spherical, 9 French spherical, and 9 French elliptical sizes, the Ardnt endobronchial blocker is a new tool to achieve direct visualized one-lung ventilation using a standard...
So after watching the 2 videos, we resume our presentation. The first modern bronchial blocker was the Univent Tube. It was introduced in 1980, and it has 2 channels, a wider posterior channel for the passage of the fiber optic bronchoscope and also for ventilation, and a small anterior channel for the passage of the bronchial blocker, which is also called the uni blocker. So the Univent Tube, made by Fuji Systems, Tokyo, Japan, is a tracheal tube with a second lumen that contains a coaxial balloon, balloon-tipped catheter, which can be advanced under fiber optic bronchoscopy and blocked in either bronchus. And this picture shows the different components of the Univent Tube. So what are the advantages and disadvantages of the Univent Tube? The advantages: it is useful in difficult airways requiring one-lung ventilation, useful in selective lobar blockage, and also it's useful in patients with tracheostomy requiring one-lung ventilation, and in rapid sequence induction that requires one-lung ventilation. And finally, it is useful in robotic, cardiac, thoracic, or esophageal surgery. While the disadvantages: the size of the Univent Tube is 8 to 9 French, which is passed through the vocal cords. It might be large enough to pass through the vocal cords. The enclosed channel of 2 millimeters is inadequate lumen to aspirate secretions, and it is more expensive. The cost of the Univent Tube is about $137, and there's a potential for inclusion in a stapling line while doing pulmonary resection. The second type of bronchial blockers is the Cohen bronchial blocker. As you have seen in the video, it has an angle tip which can be deflected using the proximal wheel mechanism. It has a bronchial balloon which is designed to block the bronchus. So the Cohen bronchial blocker has a 9 French external diameter, 1.4 millimeter inner lumen, and 65 centimeter length with angle tip. It has a high volume, low pressure, blue spherical balloon at the tip with Murphy eye designed to ventilate the right upper lobe. It has a proximal control wheel to adjust the tip deflection with an arrow on the wheel to indicate the direction of tip deflection. The third type of bronchial blocker is the Ardnt endobronchial blocker or the wire-guided endobronchial blocker. This type of blocker is ideal for difficult intubation when there is a pre-existing endotracheal tube and when post-operative ventilation is needed, and in pediatric patients. So when post-operative ventilation is needed, all what we need to do is to remove the bronchial blocker and keep the conventional single lumen tube. Unlike using a double lumen tube, which requires removal of the double lumen tube and re-intubation with a single lumen tube, which might be difficult in edematous airway. And this picture shows the different components of the Ardnt endobronchial blocker. There is a multi-port adapter proximally, and this is the conventional endotracheal tube through which the bronchial blocker passes. The bronchial blocker has a proximal end and has a distal end. It has a distal loop, guide loop, which is used to couple the fiber optic bronchoscope. And the fourth modern bronchial blocker is the EZ blocker, which is characterized by a unique bifurcated distal tip, allowing for spontaneous placement of the cuffs in the right or left bronchus. This is very interesting. It has a bifurcated distal extensions or Y shape. So as you can see in this picture, we have two balloons. One enters the right mediastinum bronchus and the other enters the left mediastinum bronchus. And one of them can be deflated at a time. So we can have a selective ventilation of the right lung or the left lung. And this is the fiber optic bronchoscopic picture of the EZ blocker in position. So the EZ blocker is an efficient, easy to use, and safe airway device and enables one lung ventilation in several clinical situations when conventional double lumen tubes are not feasible or less favorable. Now this table compares the different types of modern bronchial blockers in regard to their size, the guidance mechanism, the smallest recommended tracheal tube for axial use in millimeters, and the central channel internal diameter in millimeters. Well, whatever type of bronchial blocker is used, there should be an indication. So what are the indications for bronchial blockers? Bronchial blockers are indicated when double lumen tube insertion is not possible or advisable, as in patients with difficult airway, lesions within the trachea, severely distorted tracheobronchial anatomy, cervical spine injuries, patients who cannot tolerate periods of apnea, patients on anticoagulants, and patients who have an endotracheal tube in situ, and when lobar rather than entire lung blockade is desired, and in patients who require post-operative mechanical ventilation, and when there is a need to apply CPAP. Well, bronchial blockers have some limitations. They are more easily dislodged during patient positioning and surgical manipulation of the lung. Elliptical shaped balloons minimize dislodgement. And whenever patient position is changed, the fiber optic bronchoscope to confirm correct bronchial blocker placement is indicated. Bronchial blockers present a potential risk of perforating a bronchus or lung parenchyma, causing a pneumothorax. Moreover, bronchial blockers cause slow collapse of the desired lung. The small lumen of bronchial blockers can be connected to suction to facilitate more rapid deflation of the lung. And due to their small lumen, suctioning of just air is possible, while secretions, blood, and pus are more difficult to be aspirated, resulting in obstruction of their lumen and preventing application of CPAP. Well, lumen obstruction may be relieved by injecting saline, application of suction, or passing a wire down their lumen. Well, the last method of bronchial or of one lung ventilation is to use the conventional single lumen endotracheal tubes. Now, and advance it into the main bronchus of the non-operative lung to selectively ventilate that lung, while permitting slow collapse of the contralateral lung. This technique is hardly used in adult patients, except in rare cases of emergency surgery or extremely difficult airways. So actually, the conventional endotracheal tube is not an ideal method for lung isolation. It has some drawbacks, as seen in this picture. The endotracheal tube may be passed too low, and in that case, the distal end of the tube can block the orifice of the left upper lobe, resulting in a collapse of the left upper lobe. If we want to solve the problem and we withdraw the tube above so that the balloon will be above the level of the carina, in that case, we'll have a state of bilateral ventilation rather than block it. So it is not an ideal method for achieving one lung ventilation. Therefore, a specific type of single lumen tube was designed called the Gordon Green endobronchial tube. The Gordon Green tube is a right-sided single lumen bronchial tube that can be used for left thoracotomies. It has both tracheal and bronchial cuffs and used in pediatric patients or patients with massive hemoptysis. So it is specifically designed for the right side. Therefore, we can see the slit for ventilating the right upper lobe. Now, in this picture, we can see a comparison of the diameters of the conventional endotracheal tube, the double lumen tubes, the Univent tubes, the Ardnt bronchial blocker, as well as the intubating bronchoscope. So the intubating bronchoscopes are pediatric bronchoscopes. Their sizes start from 3 millimeter, 3.5 millimeter, and end in 4 millimeter. The conventional tube has a diameter of 7 French to start with and ends in 10 as the maximum, in millimeters. The double lumen tube starts with 28 French and ends in 41 French. And the Univent tube starts with a 6 and ends in 8.5, while the Ardnt bronchial blocker has two sizes, 5 French and 9 French. And in this table, we have a comparison of the three techniques available for one lung ventilation, which we have discussed in this lecture and in the previous lecture: the double lumen endotracheal tubes, the bronchial blockers, and the single lumen tube, showing their advantages and disadvantages. This table is very informative and needs to be read carefully. So what are the take-home messages from our lecture? The optimal technique of lung isolation will depend on several factors, including the indication for one lung ventilation, the patient's airway, the expertise of the anesthetist, and the availability of equipment. Whatever technique is ultimately used, it is crucial to understand the patient's laryngotracheobronchial anatomy, review the relevant imaging preoperatively, and gain expertise in the use of fiber optic bronchoscope to confirm position and diagnose problems that could occur with the use of one lung ventilation devices. As we have already mentioned, bronchial blockers are devices used to occlude a main stem bronchus and thus preventing ventilation of the lung distal to the site of blockade, and sometimes they are used to achieve a selective lobar collapse. They are an alternative to double lumen tubes to achieve lung isolation with certain advantages and limitations. They usually require fiber optic bronchoscopy for proper placement. Familiarity of the anesthetist with bronchial blockers is crucial. Bronchial blockers can be a very good option in certain situations, such as children and patients with a tracheostomy. And actually, the next lecture will be devoted for one lung ventilation in certain situations, such as patients with tracheostomy and difficult airways. And this is the list of bibliography used in the preparing of our lecture. And with this nice photograph of Tigris River in Mosul, I would like to end my lecture and thank you for watching and listening to the lecture. This is Professor Abdussalam Yassin Taha signing off from the College of Medicine, University of Sulaimani.